Good afternoon, everyone. Today I will be presenting a seminar on Bender Visual-Motor Gestalt Test. It is called a BGT test in short. I am Dr. Neal Kasbe, Junior Resident, SMC and CSSH Hospital. We will be going through a few things just to summarize what we will see. We will see the introduction of BGT, the importance, purpose, requirements, administration, what errors happen when the patient draws the BGT tests, the scoring techniques and tools, and common problems encountered. Problems related to scoring and problem related to administration, and the criticism related to the BGT tests. Introduction. The original Bender Visual-Motor Gestalt Test was developed in 1938 by psychiatrist Laurent Bender. The 9 designs were adapted from 30 configurations that he used to demonstrate the Gestalt laws of perception. Now there are basically 4 versions: the BGT, modified version of the BGT for preschool and primary school children, the BGT test for children, and the BGT test for young children. So these are 4 different versions of it. We will today study the most common BGT version. The BGT usually refers to as the Bender-Gestalt test by Laurent Bender. It is widely used primarily in diagnosing brain damage, neurological impairment, and visual motor perception problems. Now we have to remember that it is a screening test. It cannot exactly predict what the problem is. So it can only tell you, okay, there is some brain damage or some neurological impairment or certain visual motor perceptual problems, but it cannot tell you what exact problem it is there. So we only use it as a quick way to assess or to screen the to evaluate visual motor maturity and to screen children for developmental delays. Now because it is a visual motor test, we can also repurpose it to test for developmental delays. It consists of 9 designs which include one configuration card named as A and the other 8 as 1, 2, 3, 4 till 8. Now because I couldn't find the cards, I just drew them and I'll pass them around. You can see the designs. So you can just pass them around, and every card has certain designs, and behind them is written the number, and the number denotes what test you have to administer in what sequence. So A is like a setting card that you give it so that the test taker is set to that perception that he has to start drawing it, and then 1 to 8 is the major 8 cards on which you will test the patient. The subjects designed are then rated on the relative degree of accuracy and overall integration. These are the drawings that have been passed. So this is something that the patient has drawn. The accurate version of it, if you could quickly just pass around. The accurate version of this is drawn in the cards, and this is something that the test taker has drawn on his own. Now, what is the importance of a BGT? It is brief, economical, flexible, non-threatening, non-verbal, and extensively researched. So it is something that can be easily administered. It is a very economical test. Even if you don't have the BGT test in person, you can just draw it on a card and you can then tell the patient, or you can just print it out. So it is economical, it is flexible, and it is non-verbal. You can explain the instructions non-verbally also, and it is an extensively researched. So we have the standard deviations with this. We have different methods of interpreting the test. So it is an extensively researched thing. So what is the purpose of BGT? Although it has been most frequently used as a screening device for brain damage, its research and clinical applications extend well beyond this area. Like we said that because it is testing the visual motor aspect of a patient, we can also test it for developmental delays. It has diverse and flexible number of clinical and research uses, which results in variety of administration procedures, scoring guidelines, and interpretation systems. So it has different ways in which it can be interpreted. Within child population, it has been used to screen for school readiness, predict school achievements, diagnose reading and learning problems, evaluate emotional difficulties, study mental retardation, and as a non-verbal intelligence test. For adolescents and adults, it is useful in diagnosis of brain damage, as a projective test for assessment of personality functions. Now again, history and development. It was originally assembled by Loretta Bender in 1938 and discussed in her monograph, A Visual Motor Gestalt Test and its Clinical Uses. The basic requirement of the test is to have these cards, have a blank piece of paper which is 8.5 by 11 inch, have a pencil and keep multiple papers. It is on the test taker's decision either to use those tests or not, either to use the multiple papers or not use a multiple paper. If he chooses, he can draw it on the same piece of paper. If he chooses, then he can use the multiple pieces of paper. A sharpened backup pencil should be available and pencil should include erasers. If the test taker wants to make certain changes, they can make the changes. Though we are not supposed to give them any hint, indication or any direct instruction when the test is started. So even if it is a very direct question, we should always deviate and not give the exact answer. Now administration, when administering the BGT test, the subject or a person is given a blank sheet of white paper. The dimensions are mentioned. Although the subject is initially presented with only one sheet, but can get as many sheets as required by him. And there is no time limit of the test administration, but the time taken should be noted for significant diagnostic purpose. It is usually expected that the person will take around 5 minutes to draw one single drawing. Before starting the presentation and drawing of the designs, following verbal instructions are given to the subject by the clinical administration. I have 9 cards with design on them for you to copy. Here is the first one. Now go ahead and make one just like it. So like here we have the A. So we are supposed to hold it like this in front of the patient. We are not supposed to keep it down. We are not supposed to keep it. There is a certain orientation. If we see the A written, you should be able to read the A and you should keep it horizontally like this in front of the patient. And you are supposed to give the instruction that this is the first card. There will be 8 more such cards. So total 9 cards that you have to draw. And there is a paper, there is a pencil, and you may proceed. So we will also note the time taken for each card. So this will be the first one. Once the patient is done with it, we will note the amount of time he has taken and we will keep this aside. Then we will take out the next card, which is the 1. Like that we will go from 1 to 8. Instruction for the administrator: when the first design is completed, the next card is shown. So do not show multiple cards at the same time. Go numerically. No comment for additional instruction to be given while the subject is completing the design. Do not make any body language gestures also that the patient might be going wrong or anything. Be completely neutral. If the subject asks some specific question, he should be given a non-committal answer. The card should be held in a right angle of the figure, that is all horizontally, and the subject are allowed to hold the cards but not allowed to change its appropriate angle or turn it down during the completion of the design. If they turn it down, the clinician has to bring it back to the original position. So if the person takes the card from your hand and holds it like this, you are supposed to just make sure that it is always horizontal at all times when the test taker is seeing the card. Now there is a proper manual of BGT. It is, I think, 400-500 pages, and this is one of the pages from it. So as we can see, majority of the instructions that we have seen initially, these are the same instructions. Now what is the aspect on which we will be rating the test taker? We will be rating the test taker on the basis of errors. What errors they are going to perform while they are copying the designs. And we had seen initially, the designs did not completely resemble to what we had seen on the cards. So we will be checking for certain errors. So rotation is one error. Now there will be imaginary horizontal line over here. So while copying the design, if the patient has had 90 or 180-degree rotation, that rotation will constitute as an error. In that way, there are multiple errors. We will go through the definition of each error in the next slides. Just to go through the errors, there is rotation, overlapping difficulty, simplification, fragmentation, retrogression, perseveration, collision or collision tendencies, impotence, closure difficulty, motor incoordination, angular difficulties, cohesion. Now, as we will see ahead, 5 or more than 5 errors are considered as some kind of neurological impairments. Now, the explanation of errors. This is again taken from the module. What is rotation? Score if there is a rotation of 80 to 180 degrees, including mirror imaging of the major axis. That means the horizontal axis that we have drawn. So that becomes rotation. Overlapping difficulties. Now, if there are certain cards on which there is overlapping present. So if the patient is not able to, like on card number 7, there is overlapping present. So if the patient is not able to draw the proper overlapping, it might constitute to an overlapping difficulty. They can be of different types. There can be omission of figures of parts which overlap. There might be simplification of point so that only one point is overlapping. As we can see, there are 4 points over here which are overlapping. The patient might simplify it to 1 point. There might be mark sketching or reworking only at the point of overlap. Distortion of the figure sometimes to completely avoid the overlap at all. And figures are overlapping at wrong places. Failure of figures to overlap. So these are certain difficulties which might come in overlapping. Fragmentation, score if the figure is broken up in parts, destroying the gestalt, or if the figure is incomplete. Then there might be simplification. So here we can see that these are dots and these are circles. So it might be that instead of drawing circles, the patient is only drawing dots. So in figure 1, there are only dots. There are 12 dots in figure 1. So the patient over here might draw a dot, and in image 5, wherein there are circles to be drawn, the patient might again only draw dots. So that becomes a simplification. So there are different simplification parts. Retrogression, substitution of a more primitive gestalt from then the stimulus. So again, there are loops for circles. So instead of drawing a circle, he's just drawing a loop. Dashes for dots. So instead of drawing dots, the patient is just drawing dashes. So that is retrogression. Square for diamond or rectangles for hexagon. Perseveration. There are two types of perseveration errors. One is inappropriate substantion of features of preceding stimulus. Like in figure 1 and 2, we can see that there are dots and then there are circles. After drawing figure 1, the patient even for figure 2 is only using dots. So that is type A type of perseveration, wherein there is a preceding stimulus and the patient is following the preceding stimulus into the next image. And type B is intra-design preservation on continuing to draw a figure beyond the limits called for by the stimulus. So these are type A, type B. When you will be interpreting the BGT, you have to have the manual of BGT with you. And when you are going through figure, you have to go through all the 12 errors that are there in it. And then based on each error, you are supposed to rate each drawing. So you will take figure 1 that the patient has drawn, then you will go through all the 12 errors, and based on that you will be rating it. So when you will be rating, it is very important to have the manual with you. In the same way, there is closure difficulty, motor incoordination, angulation, and cohesion. So these sum up the 12 errors which the patient might make. Now this is a scoring sheet. So as we can see, depending on the errors that the patient has made, here it is showing in a different language. Depending on the errors the patient is supposed to make, we will score them. So the first 3 points that we are seeing are actually perseveration, rotation or reversal, and concretism. So all of those will get 4 points. So if there is the error, you will rate it as 4. If the error is not there, you will rate it as 0. So it is all or none law. You will not rate it 3, you will not rate it 2. You will rate it 4 or 0. In the second block, there is 3 points, which is added angles, separation of lines, overlap or distortion. If this is present, you will rate it 3. If this is not present, you will rate it as 0. So first block is 4, second block is 3, second block is 2 points, embellishment or partial rotation. If it is there, you will rate it as 2. If it is not there, you will rate it as 0. And 1 point for omission, abbreviation, separation, absence of erasion, closure or point of contact on figure A. So based on this, you will get a score. Whatever the score will be, you will calculate the total. So for this method of interpreting the test, always remember that it is either all or none. In the first block, it is if it is either 4 or 0. In the second block, it is 3 or 0. In the second block, it is 2 or 0. In the last block, it is 1 or 0. And depending on what error, you will give them either the score or 0 and then calculate the total. Now, once you calculate the total, you will then come to this sheet. Now, because majority of the material for BGT was behind a paywall, so this was the best picture that I could get for the standard deviation sheet. So as we can see, there are age groups 5 to 5.5. So these even distinguish the patients based on the months of their age. So it is from 5 years to 5 years 5 months, then 5 years 6 months to 5 years 11, then 6 years 0 to 6 5, and as you can see, it is up to only 11 years 11 months. So if you are using this all or none interpretation method, you can rate children up to 11 years 11 months. Now there is a 1964 method and there is a 1975 method. We will obviously take the more recent 1975 method, and whatever the score is there, that we will find. Now if we have a 7-year-old kid who on the all or none way of interpreting the test got a 7. So we will see a 6-year-old child here has a mean of 7.2. So we can say that the patient is normal, that he does not have any visual motor difficulty or any organic brain disease. But if the patient's age is 9 years old and he is still scoring a 7, then we can see it is 2.8, which means that there is some problem with the patient, and thus we have screened the patient. So depending on his age and standard deviation on the mean that we have observed, we will either say that the patient has some visual motor problem or does not have any visual motor problem. This is one method of interpreting the test result. The second method is the lax scoring system. Here we will get a sheet like this, and as we can see, it is A 1 2 3 4 5 6 7 8. Here either you will rate it as 1 or you will rate it as 0, and the 12 errors that the patient can make are over here along with the time element. So time element we usually take 5 minutes as a cutoff. You will either give a 0 or you will either give a 1, or you can leave it blank also. So you will take the first figure A. Here you will also be rating the first A figure. So here there are total 9 items to be rated. Then you will take it as A and you will go through all the 12 errors that the patient can make along with the time element, and you will either give a 0 or 1, and you will do the same thing for all the 8 ones, and then the total will be calculated over here, and then that will be added over here. Now here it is 4. So the interpretation of the previous lax method is that if it is 3 uh, 3 or less than 4, which means 3 or less only, it is negative. That is negative visual-motor deficit present in the patient. If it is 5 or 6, it is borderline. If it is 7 or 8, then there is strong evidence to support that there might be some visual-motor deficit in the patient. And 9 to 12 is very strong. So this is basically the interpretation according to the lax method. Now, what are the common problems encountered? What during administration? There can be miscalculating the subject's age. They might say that I was born on XYZ date, and as per the first method, we might calculate the months wrong or the year wrong. So there might be miscalculating the subject's age, administering the incorrect item for the subject's age, administering too many items, administering too few items, administering the items in the incorrect order, rotating or misaligning the stimulus cards during administration. So this is certain problems that the administrator will have, will do, that will be causing problems. Now on the scoring side, again, miscalculating the subject's age, inaccurately calculating the subject score, scoring based on too few items, scoring based on incorrect items, assigning scores that are too low, assigning scores that are too high. So in the first method we had seen it is all or none. So we might end up giving 4 score or 3 score for something that should have been a 0. Reading the wrong norm for the subject's age and confusing the copy and recall norm items tables. Now that we have covered the basic BGT test, its interpretation and how to administer, there are certain criticism that the test has. One, it does not provide in-depth information about the specific details and varieties of such damage. We have already discussed that it is a screening tool. It will not tell you what exactly the problem is or what area of the problem, the problem lies in, but it will screen you and give it. In fact, the Bender Gestalt is limited to relatively severe forms of brain damage, especially in the right parietal region of the right hemisphere. One difficulty in interpreting the Bender Gestalt performance is that a certain degree of overlap often exists between emotional and organic indicators on the Bender Gestalt test. Now, it might also be that the test taker might just not be interested in making the drawings, might not be in the correct emotional state to do the drawings, might be very agitated, might be a little hyperactive. So the patient might not just hesitantly draw the drawings or might not sit at one place and draw the drawings. So it might give us a false positive because we will be interpreting based on that. So we have to remember that there is certain emotional element to this also. Absence of a commonly accepted and verified scoring and interpretation system. There is no one commonly accepted and verified scoring and interpretation system. The clinicians may choose the scoring system based on their subjective approach, and this could lead to disagreement between experts and conclusions. Now, the reason why I had to take two ways of interpreting the test was because these were the two which was most commonly used. There are more forms of this test and more interpretation methods. There are certain forms of this test wherein there are 15 cards which are being used and multiple methods of interpreting. Bender is also used as a projective test, thus same criticism are true for this as for other projective techniques. Margin of false positive and false negative is present. As I said that the patient might be very hyperactive and might just hesitantly draw the drawing, which might give a false positive to us. Despite of the limitation, it remains extremely prevalent, easily administered, reliable and generally valid device for the clinician, particularly when an objective empirical method for scoring and interpretation is utilized. Now, in summary, I would just like to say that it is a very easy test to administer. The interpretation also, if we choose a certain school of thought, thus becomes very easy if we follow the norms. We have to remember that we have to see this as a whole. We cannot just rely completely on the test and say that because X is the result, the answer has to be that. We have to consider the situation that we have administered. We have to consider the patient. We have to consider the patient's educational level, the age, the setting we have been administered, and all the other environmental factors. Thank you.